I'd like to move on to Stefanie Geisler, who is our great neurology representative to our Amyloidosis Center of Excellence, and she's going to speak about neurologic involvement in AL and ATTR amyloidosis. Stefanie?
Thank you so much for this. All right, can everybody see my screen?
Great, yes, thank you so much.
Yeah, thank you so much for having me being part of this great symposium, having so many distinguished speakers there today. That's really great. So yeah, I will switch gears a little bit and talk about the neurologic involvement in amyloidosis. These are my disclosures. In general, neurologic manifestations can be observed both in acquired amyloidosis and in hereditary amyloidosis. As we have heard, the most common cause of hereditary amyloidosis is transthyretin amyloidosis. However, transthyretin amyloidosis can also happen with wild type transthyretin, so without mutation. And the other most common form of acquired amyloidosis is light chain amyloidosis. And in the next 20 minutes, I will focus on these three types. Just to remind everybody, light chain amyloidosis is due to misfolding of an immune globulin light or heavy chain produced by plasma cells. And as you know, this is very important for therapy at the end, whereas transthyretin amyloidosis is due to misfolding of transthyretin monomers. Transthyretin is a transport protein for vitamin E and thyroxine. 90% of it are produced in the liver and 10% in the choroidal plexus and in the retina. These amyloid fibrils, as we have heard, can participate almost everywhere in the body. Neuromuscular manifestation of systemic amyloidosis is peripheral neuropathy, and there it can be both sensory motor neuropathy and also autonomic neuropathy, and in rare cases, myopathy. Because myopathy is very rare, I will focus today on peripheral neuropathy. The pathogenesis of peripheral neuropathy in amyloidosis is actually not completely understood. It is thought that it is both due to a microangiopathy. Here you can see a nerve bundle, and in red with Congo red staining is the amyloid. At EM, you can see that the blood-nerve barrier is disrupted, so there shouldn't be an opening here, and here is amyloid deposition. Another hypothesis is that the amyloid has a high affinity to Schwann cells that surround small myelinated and unmyelinated axons. Here you can see thickly myelinated axons that are completely intact. But then here in the middle is this amorphous material, which is amyloid. And at higher magnification, you can see it binds to Schwann cells. By binding to the Schwann cells, it is thought that it disrupts Schwann cell function. And Schwann cells stop supporting the axons and induce axon degeneration. Hereditary amyloid, hereditary transthyretin and light chain amyloidosis have overlapping clinical manifestations. One very important manifestation, and if you don't learn anything else than this, please take this back home, is carpal tunnel syndrome. It can be the presenting symptom. In hereditary amyloid transthyretin amyloidosis, carpal tunnel syndrome was the only symptom in 33% of patients for 4 to 6 years before other organs became involved. This is very important because now we have treatment for this and we want to start as early as possible. In light chain amyloidosis, it can also predate other symptoms by over a year. Another common neuropathy is amyloid neuropathy is autonomic neuropathy, and it's characterized by dry eyes, dry mouth, orthostatic hypotension, as we have heard previously. In our next talk, we will hear more about involvement of the gastrointestinal tract, and patients can present with postprandial diarrhea, alternating with constipation, erectile dysfunction, urinary retention. And then, of course, patients present with sensory motor peripheral neuropathies. So let's start with light chain amyloidosis. Light chain amyloidosis has neuropathy in 10 to 35% of patients. It's typically not the presenting symptoms. Patients are generally older, around 60 years. If neuropathy is a presenting symptom, it frequently takes a long time to actually figure out that it is due to amyloidosis. So neuropathy is distal symmetric, sensory more than motor neuropathy. So that's a fairly classical neuropathy, but often it has more small than large fiber symptoms. And what's very important and what should start you thinking about something of something else than just a normal idiopathic neuropathy. There's quite often a concomitant autonomic neuropathy in more than 65% of patients. On nerve conduction studies, patients have an axonal pattern. Light chain amyloidosis can also present as mononeuropathy, such as carpal tunnel syndrome, and also as mononeuritis multiplex. Red flag symptoms are if your patient has also other symptoms, such as nephrotic syndrome, congestive heart failure, and very characteristic are these periorbital purpura and the macroglossus, where you can see the impression from teeth and the palate. So if you have this, it really should make you think of light chain amyloidosis. The test for light chain amyloidosis with SPEP, immunofixation, and light chain ratio. On nerve pathology, you can see a decreased density of unmyelinated and small myelinated axons, more than thickly myelinated axons. This is very unusual. Typically, in normal idiopathic neuropathies, you lose the big myelinated axons first. So this finding should make you think of amyloid neuropathy. The amyloid deposits are mostly in endoneurial blood vessels and connective tissue, and you can see the subperineural edema is shown here. Treatment, and we will hear about it later more, is chemotherapy or chemotherapy with stem cell transplant. And the prognosis may be better with an isolated predominant neuropathy than if the heart is involved. The other common form of acquired amyloidosis is wild-type trans-tyresian amyloidosis. So that's deposition of the normal wild-type TTR. It's mostly in the heart. For a long time, it actually was thought to be only to affect the heart, but we find more and more nerve involvement. A very important symptom, again, is carpal tunnel syndrome. 55% of patients in a study from Japan presented actually with carpal tunnel syndrome. And patients with wild-type trans-tyresian amyloidosis have commonly also other neurologic complications, such as stroke and TIA in 20% of patients. Very common, and it's a red flag symptom, is spinal canal stenosis, and then they have the normal sensory motor neuropathy. Switching gears to hereditary amyloidosis, trans-tyresian amyloidosis, as we have heard, there are over 100 mutations, and these mutations have different phenotypic characterizations. Some mutations cause mainly a neuropathy and very little cardiomyopathy, whereas others, and here is a wild-type trans-tyresian, cause mainly a cardiomyopathy and rarely a neuropathy. I will start with a classical presentation of V30M. It's an early onset familial trans-tyresian amyloid neuropathy. It's mainly in endemic regions, Japan, Portugal, and Sweden. Patients are less than 40 years. It has a very high penetrance, meaning that if somebody has this mutation, the chance that he gets a neuropathy is high. It presents with early small fiber neuropathy. It is characterized by distal sensory loss, pain, thermal abnormalities, and autonomic dysfunction. And then later on, large myelinated sensory and motor fibers are also involved. This is presented with impaired light touch, impaired vibration and joint position sense, distal motor weakness that progresses proximally. Classically, other organs are involved, and death happens in about 10.8 years untreated. In contrast, the late onset familial trans-tyresian amyloidosis onset is typically in patients over 50 years old. In non-endemic Asians, the V122I mutation, like in the United States, is the most common one. It has low penetrance with some mutations, and that's the reason why just genetic testing is not sufficient to start therapy. So neuropathy can have a very wide variability. For instance, patients can have only carpal tunnel syndrome. It's typically of a mixed fiber type, both small and large. It's more axonal than demyelinating. And the CNS can be involved with some mutations, Untreated death is typically after 6 to 7 years. Amyloid neuropathy is frequently misdiagnosed. The most common misdiagnosis is CIDP, or chronic inflammatory demyelinating polyneuropathy. Other common misdiagnoses are spinal stenosis or lumbosacral radiculopathy. It's if it's mixed up with light chain amyloidosis. Paraproteinemic neuropathy, patients can have both a paraprotein and a genetic amyloidosis, with idiopathic axonal neuropathy and with amyotrophic lateral sclerosis. Red flags to think about is familial transthyretin amyloidosis is more likely in early onset patients. And if you have a progressive sensory motor neuropathy and positive family history, carpal tunnel, or autonomic or GI dysfunction, unexplained weight loss, cardiomyopathy, and renal and ocular involvement. Other red flag symptoms are rapid progression and failure to respond to therapy. So there was the following expert consensus recommendation to improve the diagnosis of ATTR amyloidosis with polyneuropathy. The consensus is that if somebody presents with an idiopathic, rapidly progressive sensory motor axonal neuropathy or atypical CIDP, and atypical means it doesn't respond well to normal treatment, and at least one of the following: positive family history, bilateral carpal tunnel, autonomic dysfunction, gait disorder, unexplained weight loss of more than 10 pounds, cardiac hypertrophy, heart rhythm abnormalities, vitreous opacities, and renal abnormalities, then one should think of ATTR amyloidosis with neuropathy. We diagnose it by history and physical examination. We think of the red flag signs and symptoms. Testing is histopathology. We like to identify the amyloid in tissue, either fat bed biopsy. Nerve biopsy is typically not taken. Other locations are lab and cardiac biopsy, and then we do mass spec, sending it to Mayo, and then patients require genetic testing. Treatment, and that's probably the most exciting area right now. So it's either treated by decreasing the production in the liver or by stabilizing the tetramer. Decrease the production can be through liver transplant, and this has been done in the past mainly. It did show decreased mortality and longer survival. It arrested the progression of neuropathy. However, there was no recovery of organ function, and obviously it is a problem with immunosuppression. Now we have decreased translation of transthyretin with siRNAs and antisense oligonucleotides, and we have the TTR stabilizers. The stabilizers were discovered first. Diflunisal is one of them. It's a non-steroidal anti-inflammatory drug. In a randomized placebo-controlled clinical trial, it showed significant reduced neuropathy progression, but the trial had high dropout rates and risk for cardiac and nephrotoxic side effects dampened enthusiasm. It's still not FDA approved for ATTR amyloidosis. Tafamidis is also an anti-inflammatory drug, but it does not have the cyclooxygenase inhibitory properties. And that's why also less risk for cardiac and nephrotoxic side effects. In a randomized placebo-controlled clinical trial, it stopped neuropathy progression in 60% of patients and showed an improvement of quality of life. So long-term follow-up showed that a third of patients were responders, a third partial responders, and a third non-responders. It is currently FDA approved for stage 1 amyloidosis with polyneuropathy. A lot of excitement comes from the discovery and treatment with RNA therapeutics. Right now we have on the market patisiran, which is a double-stranded siRNA, and inotersen, which is an antisense oligonucleotide. Patisiran, as a double-stranded siRNA, does not bind to plasma proteins. Because of it, it requires lipid nanoparticles for transport and hepatic uptake. Because of that, it requires an intravenous administration. And because of that, there's a potential for immune reaction, and pre-medication with corticosteroids and histamine blockers is necessary. Inotersen is an antisense oligonucleotide. It has a high binding affinity to proteins and which enables easy distribution in the body. Because of this, it can be given subcutaneously, but as a class effect of of antisense oligonucleotides, it can cause thrombocytopenia as a side effect. Just briefly, the oligonucleotides. So here's drugs. Inotersen and patisiran both block the mRNA for transthyretin, both wild type and mutated, and it decreases transthyretin production. The landmark trials are with patisiran is the Apollo trial, and inotersen is a new TTR trial. They were very similar. Patisiran was 18 months with 225 participants, and inotersen 66 weeks, which is almost the same, and 172 participants. Patisiran shows that placebo-controlled patients continued to have neuropathy, whereas patients with patisiran, not only the neuropathy was not only stalled in progression, but they actually improved. In inotersen, you can see that the neuropathy progressed much less than in the placebo treated group. Excitingly, patisiran showed an improvement in almost all areas of autonomic neuropathy. This is a scale, and also is particular in orthostatic intolerance and GI symptoms. And inotersen also showed less progression of autonomic symptoms. Patisiran is given 0.3 mg/kg IV every 3 weeks. It led to 81% reduction in serum TTR, improvement in neuropathy score, autonomic neuropathy score, quality of life, and cardiac markers. Inotersen is given subcutaneously weekly. It had 75% reduction of serum TTR. It also showed lower neuropathy scores than placebo group, higher quality of life, and improvement in some cardiac markers. So most common side effects of patisiran are peripheral edema and infusion reactions, and pretreatment with corticosteroids and histamine blockers are necessary. Inotersen had thrombocytopenia in 60% of drug-treated patients. Unfortunately, there was one severe side effect with intracranial hemorrhage and death. Other side effects are nausea, vomiting, fever, and glomerulonephritis. That's why frequent control of blood cell counts and renal functions are necessary while treating with inotersen. So long-term open label extension trial showed that patients who were on placebo, that patients who were on patisiran continued, the improvement continued. They did not get worse over time. Interestingly, patients who had been on placebo, the progression stopped, but they did not come down, as well as patients who had been on patisiran the entire time, which indicates that the treatment should start early. Similar findings were found with inotersen. And that's my last slide about next step. There are really exciting developments right now. Patisiran is further developed with an enhanced stabilization chemistry, adding some sugar moieties, and is currently in clinical trials as vutrisiran. 25 milligram are given subcutaneously every 3 months. The TTR plasma level was reduced by 90% and had no serious adverse events. It's currently in a phase 3 clinical trial. Similarly, inotersen has been further modified to give enhanced uptake and specific targeting of tissue. It's given subcutaneously every 4 weeks, and preliminary results also show that it's well tolerated and decreased TTR by 94%. And also, and probably you might hear about it later a little bit more, there are also mutation targeting antibodies in development, which would target a specific mutation and not the wild type TTR. To summarize, so the neurologic involvement in amyloidosis are peripheral neuropathy. Carpal tunnel can be the presenting symptom. Bilateral carpal tunnel is a red flag symptom that should make you think of amyloidosis. Other red flag symptoms are autonomic GI dysfunction, unexplained weight loss, cardiomyopathy, renal ocular involvement, and rapid progression. And then there are the exciting developments for gene therapy for amyloid TTR, for hereditary amyloid TTR. That's all. Thank you.
Fantastic. Thank you so much, Dr. Geisler. That was really great.